now.
Great. Thank you so much, Caitlin, for inviting us. It's great to be in this conversation with you all. Camille, do you want to introduce yourself first?
Sure, yes. Hi, everybody. My name is Camille Kramer. I'm a senior research program manager at Johns Hopkins. I work on Carolyn studies and have been with her team for about 7 years now, and I'm also a doctor of public health student.
And I'm Carolyn Sufrin. I know some of you, and I am an OBGYN at Johns Hopkins. My clinical specialty is not addiction medicine, it's complex family planning. I've been working in carceral health care, both as a clinic, not both, multiply as a clinician, research, policy, advocacy for nearly 2 decades. And you can't practice in a carceral setting and not encounter folks with substance use disorders. So that is how I came to be involved in research related to perinatal opioid use disorder in carceral settings. And the work that we're going to present today, it was prompted by one of our recent publications. Caitlin reached out to us, and we will highlight, we will go through some of the findings and methods of that article. But that article is along a continuum of research that Camille and I have been doing for nearly 8 years now. That started as a K. In fact, Caitlin, I feel like I even visited you when you were maybe a fellow or something, and I was yes, Mishka has also been on these projects as well. So definitely acknowledging our many collaborators, which we will do again at the end. So just very briefly about our research team, we call ourselves RWIP, which stands for Advocacy and Research on Reproductive Wellness of Incarcerated People. If you feel like scanning the QR code and going to our website, or you can just do arrwip.org. You'll find a lot of information. We have all of our publications there, but and feature some of our studies where we also have summaries of them, as well as just a bit about our broader commitments. And you can see here our approach and our vision and our values, that we are focused on a broad vision of reproductive wellness for people who are enmeshed in the criminal legal system. And we recognize that really that means not incarcerating them in the first place. But we also recognize that abolition is not going to happen overnight or anytime soon, and that we must work towards systems that can provide compassionate, evidence-based, patient-centered care for this population, whether that's in the facilities or outside. And that's a lot of the vision that we're oriented around. So we conduct mixed methods research that can be useful for people in the field, for policymakers, and also for filling in data gaps. This is a population that is overlooked, and we know very little about pregnancy outcomes for incarcerated individuals. So that's just a little bit about our overall research team's missions. And what we're going to talk about today, obviously the focus of this group is our work on perinatal opioid use disorder treatment in jails. But before getting into that research, just a little bit of background. And some of you may be very familiar with this background. Some of you may even practice in jail or prison settings or take care of patients in the community who are incarcerated or recently incarcerated. So I want to honor that. And I also am eager to hear from your experiences during our discussion. But just some brief background and statistics. The latest estimates that we have from the Bureau of Justice Statistics, BJS, are that there are close to 200,000 females who are incarcerated on any given day in the United States. Those numbers have risen exponentially since the 1970s and 1980s as part of the racialized phenomenon of mass incarceration. And the numbers did fall during COVID. But we are already seeing them tick back up, and the rise in number of females behind bars is actually greater, or it's greater for females than it is for men, the post-COVID increase. So it's probably soon going to come close to pre-pandemic levels as well. Most of the women, and I am going to be talking about women, especially when we are citing statistics, because that's how they are reported. But we very much acknowledge that there are people who do not identify as women who have the capacity to be pregnant. None of our studies have enrolled, all people who have participated in our studies have identified as cisgender women, but I do acknowledge the gender diversity. So most of these women are of reproductive age, and in fact, the majority of them are mothers and primary caregivers to young children. So that has a huge ripple effect on children's and families and communities' well-being when these mothers are incarcerated. But because of this age, prevalence, because these are already women who are mothers and have reproductive capacity, we also know that some of them will be pregnant at intake. Estimates from our team's previous study are that there are about 58,000 admissions of pregnant individuals to jails and prisons each year. These are people who have many susceptibilities to adverse maternal health outcomes. Incarcerated women, not necessarily pregnant women, but what we know about incarcerated women is that 70% of them have mental health diagnoses other than substance use disorder, and also 70% of them have substance use disorders. Most of them have experienced profound traumatic events or experiences in their lives, whether it's sexual trauma, physical trauma, emotional trauma, and also the trauma of poverty, racism, and gender-based violence as well. And the connections between various social, systemic, structural factors that have contributed to the distinct ways that mothers, especially Black mothers, experience incarceration, those things cannot be disentangled from other systems, such as the family policing system or the so-called child welfare system, and the ways that the courts and other laws have criminalized, especially substance use in pregnancy, particularly in distinct ways for Black mothers. Indeed, there are racial disparities in female incarceration rates, with Black women incarcerated at nearly twice the rate of white women, and Indigenous women at about 4 times the rate of white women. And many of us are OBGYNs, and those are very similar disproportionalities when it comes to pregnancy-related death. So it kind of becomes hard to ignore that there might be a lot of connections between the maternal mortality crisis in the United States and mass incarceration. And in fact, that is a new study that our team is embarking on that is not specific to substance use disorder, but we've just started a project to look at rates of maternal mortality and infant mortality in this population. So there's a really important and interesting legal context for care for incarcerated people, which is that they have a constitutional right to health care. That's based on the Eighth Amendment's prohibition of cruel and unusual punishment and a landmark case from 1976. So even though there's this constitutional requirement for prisons and jails to provide health care, there's actually no agency that exists to deliver healthcare services, to set standards, to provide oversight. So healthcare delivery is completely variable. At some places, some facilities, it's a robust, full scope of care, and at many places, it's completely bereft and absent. So how does incarceration, what are some of the intersections between incarceration, pregnancy, and opioid use disorder? Well, I've already highlighted the high prevalence of substance use disorders in general in this population. Our research has estimated that among the pregnant folks who are admitted to jails each year, that about 14% of them have an opioid use disorder. And we extrapolate that to be close to 8,000 admissions of pregnant people with opioid use disorder admitted to jail. So there's a lot of them. And we also know, independent of pregnancy, that release from incarceration in people with and without opioid use disorder is an extremely high-risk time for death. Those 2 weeks after release, in part because most people aren't getting treatment in jail or prison. Then they get released, their tolerance has changed, they return to use, and they're much higher risk of fatal and non-fatal overdose. And a study out of Massachusetts found that incarceration during pregnancy increased the risk of postpartum overdose by 4 times. So it is a risk factor for postpartum overdose as well. So lots of connections and lots of reasons why jails and prisons are an important point of access, though I don't want to say opportunity, because ultimately these are places of confinement and punishment, but an important point of access along the cascade of care for access to evidence-based treatment for opioid use disorder. So we know it's important. We know it has the potential to save lives. However, what do we know about what's actually happening on the ground? So I'm borrowing this structure from Jeannie Kelly at Journal Club. I think it was last month. She used this theater metaphor of Act 1, 2, and 3, and it was like, oh, that's so useful for organizing the different phases of the work Camille and I've been doing the last 8 years. So Act 1, we're going to review our research where we analyze sort of what is the availability of services of MOU access to MOUD for pregnant folks in jails. And I will say this research focuses on jails. There are differences between jails and prisons. I won't go into too much, but briefly, jails are short stay facilities. They're for people who are pretrial and haven't been convicted of a crime or are serving a sentence for a misdemeanor or are awaiting their sentence, whereas prisons are longer term and people who've been convicted of a crime. Jails are in flux with the community. There are a lot of important connections, and we really should be seeing all of these institutions as part of the community and recognizing those connections. Act 2, Camille will review some qualitative research with people with lived experience, and Act 3 will highlight a resource that we developed and that we've been implementing with a few jail sites across the country. Okay, Act 1, Scene 1 is what is the availability of medications for opioid use disorder for pregnant and postpartum folks in U.S. jails. There's our citation. Of course, you'll have the slides too, so don't worry if you don't have time to scan the QR code, although it's on all the slides. So we conducted a national survey of all known U.S. jails. And I love these photographs. This is Camille's massive organization and we had some students helping too, of how we sent out over 2,000 paper surveys. We did do red cap surveys, but I will tell you, if anyone's interested in doing survey research with people who work in or run jails, most of them don't respond to web-based surveys, but they do respond to paper surveys. So we did it both ways, but got more responses the old-fashioned ways. Getting the access to the database of jails was actually, that's a whole nother story, and we do have a publication about that. But there is no such, prior to the study, there wasn't such a database. We were given access to one that researchers at George Mason University created. But the fact that we don't even know where all the jails are in the United States is very telling. And we just wanted to know what do you do for pregnant and postpartum folks with opioid use disorder in terms of access to methadone and buprenorphine withdrawal practices. We sent it out to nearly 3,000 jails. We got over 1,000 responses, 836 of which were usable and valid. And you can see we had a pretty good distribution geographically. And this is a summary of our key findings. 60% of jails said that they would continue a pregnant person on MOUD if they were on it in the community. And that didn't necessarily mean they initiated it. It also didn't mean they continued them on the medicine they were on, because some jails only offered methadone and some only offered buprenorphine, and they would just, give you what they had. Only 32% did both, initiate and continue. And if the gold standard is to initiate and continue methadone and buprenorphine, only 18% of jails did that. And we define access not as necessarily having it on site, being able to prescribe it or dose it, but having an arrangement in the community, offsite transport. So only 18% of jails were providing the standard of care. This was in 2019 when we sent these surveys out. Just as alarmingly, but sending a different message, even at the jails that provided MOUD in pregnancy in some capacity, most of them discontinued it postpartum, whether it was through a taper or just abrupt cessation. But the message to me is very clear. They only cared about these individuals in as much as they were gestating a fetus. And after that, they were not concerned about continuing medication. We asked a number of other questions in the survey about some implementation barriers, but this really highlighted and corrected a misconception, at least in the field of correctional health care, where there was this assumption like, well, yeah, jails are doing a terrible job of providing MOUD, but at least they're doing it for the pregnant women. And we showed that, in fact, not. Okay, I think I'm turning it over to you now, Camille, or is it still me? Okay, still me. All right, so then we also we followed up on these surveys and invited jail administrators and clinicians to engage in qualitative interviews so we could understand their perspectives on providing treatment to people in pregnant people in custody. And we also wanted to understand more deeply implementation barriers. And I'll tell you, just as a sort of overview, you would think that we would maybe have some response bias where we would only get people who were committed to it and interested in it. And we had a varied sample and plenty of people with stigmatizing views of this population and of MOUD treatment in general. So we really, again, there were other studies of implementation barriers and perspectives on MOUD in jails, but none that were specific to the perinatal issues. So that was really what our interview guide was focused on. And we ultimately interviewed 28 people, broad geographic range, and it represented 23 jails throughout the country. All of the jails in our sample provided some form of MOUD in pregnancy. So that was a little bit skewed in terms of who agreed to be interviewed. But there were certainly variability in the attitude. So here are the three major themes that we found in our study. And this was the paper that recently came out that prompted Caitlin to invite us. So if you are interested in more detail, please do check out the QR code. I will also say that in our results, we framed our results in the publication through the lens of implementation science and the CFIR, the Consolidated Framework for Implementation Research framework. But for here, just for simplicity purposes, we're going to just highlight the key themes of our interviews. So these jail administrators and clinicians did identify that there were some pregnancy-specific factors that made it challenging, but also provided some opportunities to make MOUD available for pregnant folks in jails. And that included that, they didn't have anyone with pregnancy expertise, and some of their partners in addiction medicine or primary providers were just kind of afraid and nervous about the particularities of dosing in pregnancy, et cetera. Especially for methadone, taking people off-site for daily dosing was perceived, understandably, from their perspective, to be a security risk and it also is a staff burden for transports off-site, and few of these jails had the ability to dose methadone on-site. But we also found the perceived lack of need for pregnancy MOUD care. Like, oh, we don't really have any of these patients. Well, really, if you're not collecting data about it, how do you know? And some people highlighted that they didn't have enough resources to care for these patients. But others said, you know what? If we can make the case to our local government or to our warden that we need this for the pregnant women, then maybe we'll start doing it for everyone. So some people saw this as an opportunity. We also found almost universally that participants really prioritized fetal well-being, and that informed their motivations for making this available. What was best for the baby, and that's also why they discontinued it postpartum. We found, not surprisingly, but disappointingly, a lot of stigma and judgment. Also, a lack of knowledge around substance use disorder in pregnancy, misconceptions about breastfeeding, about neonatal opioid withdrawal syndrome, but also just negative views about these women being unfit mothers. Here are just a few key quotes. And, Camille and I when we were looking at these slides, we're like, oh, there are too many quotes on here, but they're all so good. So we have a few highlights. Someone said, it's not a big need. We just don't have a lot of pregnant women. So whether that's actually true or not, that is the perception. And, from our perspective, as long as it's a non-zero number, you still need to have systems in place. You may not need to be a certified OTP for your jail, but you need to know where to take patients for the treatment they need. Another said it's a big deal to bring them out of jail. There are shackling restrictions, those sorts of things. Another felt that it was wrong to treat somebody with a drug addiction with drugs. So there's still this pervasive understanding that MOUD is not treatment, but it's just feeding the addiction. And then there's an emphasis again that it's for the baby. There was also this reinforcing notion that MOUD in pregnancy didn't work. We see the participants had their idea of what it means to work and didn't understand the sort of recurrent nature of addiction and that recovery is a process. Also, that there are parallels with incarceration. Some of them come back to jail within a week of the pregnancy, the week that they're due for selling drugs. It doesn't seem to have much positive effect. And then there was also a lot of resentment, like, oh, you don't care about your baby, you're just using in pregnancy. We care more. So, in summary, we found a lot of perspectives and a lot of resistance, but we also found some opportunities for implementation and some desire for resources. So, now I'm going to turn it over to Camille, and Camille, be sure to tell me when to advance the slides.
Thanks, Carolyn. And the QR code for this publication is also on the slide. But a part of the study, we also interviewed people with lived experience. So currently and formerly incarcerated pregnant and postpartum people with OUD in jail. Next slide. Next, oh, you got it. Okay, methods and demographics. So we did qualitative interviews from 2020 to 2021. We recruited people from 4 different jails and 3 different community OTPs in 4 states, including Virginia, Florida, Maryland, and Ohio. And we asked some questions about structural barriers to getting MOUD, transitions of care when they become incarcerated and when they get out. We talked about power dynamics, the trauma of incarceration, and values around opioid use and treatment in pregnancy. Next slide. There are many different demographics for this population that we collected. Carolyn and I also discussed this, and it was just too much to put on the slide, so we just wanted to highlight a few. Half of our sample, we interviewed them while they were in jail. The other half, they were in the community. Majority of them were pregnant with 23, 9 were postpartum. Most of them did get some form of MOUD in jail, but you'll see that many of them also experienced withdrawal. And I'll talk more about that. Oh, sorry, Carolyn. Many of them were previously incarcerated, had a history with the child welfare system, and experienced unstable housing. Next slide. There were 5 themes that emerged from these interviews. The first one being that there's a lack of counseling and accurate information about MOUD in pregnancy. This directly aligns with what Carolyn was talking about. Jail staff are not equipped to have these conversations. They know very little about pregnancy MOUD care or MOUD in general. So many pregnant folks did not have information on what their options were and received a lot of misinformation. Next slide. Care was absent, delayed, or coercive. Some folks got no care at all. Many of them were forced to go through withdrawal until treatment was started. And then some folks also talked about being pressured to get on treatment when they felt like they didn't have options or enough information to make decisions. Like Carolyn mentioned, there are many experiences of stigma and discrimination from staff and caregivers. I'll also share some quotes. So even at jails that were providing MOUD, those experiences were still very traumatic for patients. There are a lot of structural barriers to safe transitions of care and continuing MOUD, both when people come into the jail and when they get out. And I'll talk more about this later on a separate slide, but it posed challenges for continuing treatment. And then many of our participants had child welfare involvement, and that in the presence of child welfare, they really talked about was an added pressure. Whether they were on treatment or not, child welfare was involved, and it was just more anxiety and more pressure for them to continue on treatment. Next slide. Here are some quotes. And again, these quotes are a little bit long, but we highlighted the most important part. The first one says, "The only thing we talked about when I told the doctor I was getting high and I was trying to get into a program, he said, 'We don't do none of that here, and we don't have anything for you.'" The one on the right says, "I don't want to lose my kid, and all I get told is, 'Well, you should have thought about that before.'" Like they just talked to me like I was dirt under their feet. And this person continued to talk about how that experience influenced her treatment-seeking behaviors when she got out because she didn't want to be treated like that again. And then the last one talks about CPS. I think it's very strange that even when you're on Suboxone, so when you're on MOUD and you're doing the right thing, CPS will fully investigate you and be involved in your lives for a period of time. And that presence of CPS, even when they were on treatment, was a lot of pressure for them. Next slide. So there are structural barriers to safe transitions. Jails, reentry programming in jails is lacking in general, but especially for pregnant folks. Jails release women with no support or reentry services for prenatal care nor continuing MLUD. Jails that don't offer MLUD deterred women from continuing treatment. We heard from a few folks in our sample that they knew they were going to jail and they were already on treatment before they went to jail, but they decided to detox themselves before they got to jail because they knew that they could do it in a less traumatic way. And then there's a lot of miscommunication or coordination between courts, jails, and OTPs to make sure that there are smooth transitions of cares. We've heard that sometimes courts will mandate a pregnant person to go to jail and be in treatment in jail just to find out that that jail does not offer treatment. So there's just a lot of miscommunication and missed opportunities. Next slide. So in summary, patients are not given a choice of treatment nor adequate information to make decisions about themselves. They are forced to go through withdrawal, even at jails that offer treatment, which is very traumatic. And we've heard, and I don't know if this was echoed in our results, but everybody in our sample, their main concern was the baby. Like, is this okay? Is going through withdrawal, is being on treatment, is this okay for my baby? Or how is this affecting the baby? And then there is, like we both mentioned, there's a lot of work that needs to be done, even at facilities that offer treatment. And that includes improved counseling and information, making sure folks are started on treatment right away and avoiding withdrawal, linking people to care once they get out. And then also that patient interaction is very important. So reducing stigma and discrimination. Next slide. Oh, you want to add something, Carolyn?
Yes. So we all know what what the evidence-based care is for pregnant people and postpartum individuals with opioid use disorder, right? They should be offered and recommended treatment with methadone or buprenorphine and provided with wraparound services, non-judgmental care, all of those things that we know and practice. And a version of that is what should exist in jails as well. And how that should play out, of course, is that if a pregnant or postpartum person comes into a jail and they have opioid use disorder and they're already in treatment, obviously they should be able to continue that medication at the right dose. And if they enter jail or prison not on medication treatment, then they should be counseled and initiated treatment as soon as possible with methadone or buprenorphine. And again, they may not have the capacity, jails may not have the capacity to do everything on site or the skill set, and that is fine. I'm sure we all have taken care of people who come to our L&D units for a day or two for titration and stabilization from a carceral facility because they don't feel comfortable. They should have counseling on birth expectations, expectations on nows, postpartum, breastfeeding, all that stuff, and then preparation for reentry and community linkages, both for continuing their MOUD and prenatal care and other care and services as well. And they should have, while they're in custody, as they need dose assessments and dose adjustments, that should also be there. They should have also have access to abortion care as needed, although that, of course, is now highly restricted by and variable by state. And all of this care should be non-judgmental and patient-centered. There are a lot of moving parts in that, of course, but that's kind of obvious, I think, to all of us. But making that happen in a setting that is as inherently dehumanizing and coercive as a jail is very challenging. But I also want to acknowledge that there are providers who work in jails and prisons who are extremely compassionate and do have the skill set and the patient-centeredness to be able to provide this. It's just not at every facility. And of course, for postpartum care, they should be able to continue it, have appropriate dose adjustments, be allowed to express breast milk for their infants, and also be supported so that their risk of overdose when they get released is minimized. So all of these things we know need to happen, but our landscape studies identified many of the challenges. But they also identified some opportunities. So I'm going to turn it back to Camille.
Yes, so for the third and final act, I'll talk about how we use all of our prior research to create and pilot a best practice toolkit for perinatal OUD in jail. And this resource is called Mom Care. Momcarejail.org is publicly available if you wanted to check it out. But like I said, so we used all the research we just talked about, and we had students do an environmental scan for us to create and pilot mom care. Next slide. Before I talk about some of the content that is on the website, I'll talk about the design of the website. So we first created a prototype working with web designers based on our formative research, as well as the environmental scan that we did to see what was out there at the intersection of perinatal health, OUD, and incarceration. We used that prototype to conduct focus groups with 3 different audiences. One audience we actually recruited from this group, so some of you in this audience may have helped contribute to this project, so thank you. But we conducted 3 different focus groups showing the prototype to both community providers who care for this population, jail staff, and then people with lived experience to get not only their feedback on the content that we had on mom care, but the organization, the flow, using it, everything, all in the above. So we took that feedback and revised mom care. I think we did it a few times. After each one, we revised it slightly, revised mom care, and then we came up with a final version that went live. Next
And I'll
slide.
just add,
Yeah.
the goal of this website was to provide like brief clinical guidance as well as implementation guidance and resources for for staff in jails, whether they're clinical staff or custody staff, to be able to do the right thing, to provide whatever their job role was when they encountered a pregnant or postpartum person with opioid use disorder, and they were like, what do I do about this? They would be able to find quick information that's curated, that's not like a 75-page PDF for them to sort through. And that also, well, Camille will talk more about the components, but this is staff facing, and the goal is to help support them. When we were building it, I was almost thinking of it, although it's designed very differently than this, but like up to date. I don't know about you guys, but I don't see pancreatitis in pregnancy all that often. And so when I have someone who comes in, like, once every 6 years, and I'm like, I go to up to date, I'm like, right, that's right. Those are the labs and the fluids and all of that. So it's like, oh, right, I know where to go for this information so that I don't have to worry about memorizing it.
Thanks, Carolyn. Next slide. I'll briefly talk about the feedback we got from the focus groups on the prototype. Some from jail staff and community providers, they really emphasize the need for this resource. There's not a resource out there at this intersection, and that was lacking. And so this filled that gap. They stress, especially jail staff, stress the practicality of one-page reference guide. So things that they could look over very quickly, things that they could print out, things that they could post. Like Carolyn and I mentioned, jail staff are very old school. They want paper copies of everything. They suggested ways to introduce the resource to other staff. So either through onboarding, orientation, or trainings of other staff. They provided recommendations on the content organization, which I'll show you an example page in a little bit. They also describe challenges for caring for this population during reentry and while in jail, which we try to embed that information into mom care. And then we identified some best practices and key messaging to emphasize the resource. And this mostly came from the community providers, so people like you all. So making sure that MOUD is continued postpartum, not switching from methadone and buprenorphine, emphasizing that MOUD saves lives, and that patient-centered diversion responses. Diversion is a huge thing in jail. So the sharing, selling, giving of someone's medication to somebody else. And that is what we've heard from a lot of jail staff. That's the main reason not to do it and or not to implement MOUD. And their response to that is just cutting off medication altogether, which we know is very punitive. So alternatives to dealing with that. Next slide. We also share the prototype with people with lived experience. And this is a separate group than the group we previously interviewed. So pregnant and postpartum people with OUD who were in jail. None of them were in jail at the time of our interview. But we showed them the prototype. They went through it on their own before meeting with us. And then they really just shared their thoughts and their feelings and whether it spoke to their experiences. So they talked about how they felt isolated and uninformed and dehumanized in jail, and that mom care helps prevent those experiences. They emphasized the need for trauma-informed care, patient education resources, reentry services, and mechanisms to bond with the baby after release. We created some patient-provider scripts, so word-for-word scripts that jail staff can use when having conversations with people, and they really appreciated those. And one thing we did not have on Mom Care at the time of this was we didn't have a page on miscarriage and pregnancy loss. And someone in our sample had experienced that, and she was like, you really should add a whole page on that. And so we thought that was a great idea, and we did. And there's a quote on the right from someone who participated. She says, jail staff should consider everything on your website and actually take a look at it and really think about how they treat pregnant women or women who are pregnant and detoxing in general, because we're humans too, and we're growing a human. Next slide. This is a snapshot of how the website is designed and organized. As Carolyn said, we have two main focuses of information, well, three really, of information. One, under the Pregnancy OUD Care tab, that is clinical stepwise information from intake to discharge, so telling jails exactly what to do, how to triage patients, how to screen them for pregnancy, opioid use, other substance use, what discharge planning can look like, so on and so forth. The implementation tab is more so for custody leaders. So that is for either creating a program or expanding an existing program. So on that tab, we have things of like different ways that you can do MOUD inside of a jail, whether you have a provider on site, whether you transport patients. We have information in there about funding. We have information in there about staff training and protocols and so on and so forth. And then the last tab is the resources tab. This tab has both resources that we've collected from outside places as well as ones that we created specifically for mom care. And I'll show you some of those as well. This is an example of what the page looks like. This looks totally different from our prototype. One of the feedback that we got, I think from people across the board, was that the content was very dense. So we decided to create 3 different tabs of content. So if you really just want the key points, you go to the key points tab. It tells you how to do this, why it's important, and things to keep in mind. The deeper dive tab has FAQ-like responses. So if you want more information on a certain topic, you can go to the deeper dive tab. And then the resources tab has both resources we collected as well as resources that we found that could be useful for jails. And I know, Carolyn, you wanted me to highlight, but we also have on all of the clinical pages, the National Maternal Mental Health Hotline number, because we think that's a wonderful free resource. And we checked that people in jail can call that number and still speak to somebody and not have to pay. So we share that with all of our sites, and many of our sites incorporate it into their daily practice, with one jail putting it on their free call list. So anybody in the jail could call that number for free without even asking, which was, yeah, very innovative.
Yes, that's for patient facing. And I also wanted to highlight the National Clinician Consultation Center, the substance use warm line. And some of you may even consult on that. I know that Mishka Turplin does. So we have that for clinicians to be able to call people in jail to know that they can call.
And now I realize I just highlighted the wrong number. So sorry about that. Next slide. Okay, so here are some screenshots of the key resources on mom care. These are the resources that we created specifically for jail staff. I know these are kind of tiny, but the one on the left is a screening algorithm. So it takes you stepwise. If you have someone present at your jail, this is what you need to do. And it tells you which direction to go in, whether they're pregnant, they're postpartum, what their symptoms are, if they're showing signs of withdrawal for opioid use disorder, and how to triage them. The one in the middle is a reentry checklist, and we adapted this from an existing one, but we added pregnancy and postpartum specific things. Uh-oh.
Sorry, I was trying to put something in the chat and I think like my share got messed up. I'll keep going, Camille.
No worries.
I'm back.
But yes, so the checklist talks about pregnancy, postpartum needs. It talks about basic necessities for anybody getting out of jail, and it also talks about opioid use disorder needs. And then the one on the right, we heavily emphasize in our sessions with jail staff, which I'll talk about, recognizing urgent maternal warning signs. And that's something Carolyn and I failed to mention, that although mom care is specific to opioid use disorder, we embedded and baked in information about pregnancy across the board and postpartum across the board. So the resource could be useful for any pregnant or postpartum person or jail staff caring for pregnant and postpartum people with or without OUD. And that resource on the right talks about training on recognizing urgent maternal warning signs. Next slide. I'll briefly go through these. The one on the left is recognizing labor signs, printable one-pager you can put up. The one in the middle talks about, it really covers misconceptions about OUD and pregnancy. So 10 things correctional officers need to know, another postable document. And then the one on the right are some sample scripts and using person-centered language for communicating with patients.
I will highlight that this messaging of harmful for the fetus, we know that the story is more complex in terms of the impacts and the direct versus indirect connections, but this was really conveying the nuances of that and the risk of preterm birth, but not this, but not that, just having more of a global simplified view of it. We recognized and our research showed that that's what would get people to listen and pay attention. So we really simplified that message without getting into the nitty gritty of what the evidence base shows in terms of doesn't actually, is it associated with miscarriage? All the nuances we all know, and just the simple message.
Next slide. One thing jail staff who are participating in the pilot, and I'll talk about what the pilot looks like in a second, one thing they really communicated to us was wanting resources for patients. They know that they don't necessarily have the skills, the knowledge to have these conversations, but they wanted something they could give to patients to help with bridge that gap. So we curated, some of those are existing, but we also created a number of patient-facing resources about opioid use disorder and pregnancy in a jail setting. The one in the background is It's Never Too Late to Get Treatment for You and Your Baby. We talk about the basics of treatment, what that looks like for breastfeeding, what that looks like for giving birth, pain management, so on and so forth. And then it came up throughout the study, it came up again, how to have conversations to choose the right medication. And there weren't many resources out there of deciding between methadone and buprenorphine. So we also created a resource for that. And both of these resources have been reviewed by people with lived experience. And they gave us some great feedback. And there's quotes on their experiences in there as well. You want to keep going until all the things show up? I know we're going to run low on time, so I'll just go through this briefly. So after we created the final version of MOM, and I wouldn't say final version, we still make changes all the time. So if you see something on the website that you want to add or is not working, let us know. But we recruited 5 different jails across the country of different capacities, different sizes, had different levels of pregnancy care and different numbers of pregnant folks and postpartum folks to be a part of a pilot program. And so what that pilot looked like is they worked with us for a full year through facilitation sessions and technical assistance in which we were delivering mom care content to them over Zoom sessions as well as asynchronous sessions. So we met with them regularly. They could access the website at any time, but we met with them usually once or twice monthly to talk about special topics. Sometimes we chose the topics, other times they did, or we did it collaborative. So we would ask them, what's a challenge or a gap you have right now in your jail, or what do you guys need help with? Some of them came up with topics like, oh, we really want to train staff on this. Actually, a director at one jail, which is not opioid use related, she was saying there's a lot of stigma around abortion. Can you create an abortion resource for us? So we did. So we really catered those topics to their needs. During that time, we also worked with a site champion. So this was one staff member from each core team, and there were 2 to 6 people per jail that participated in this. And we met with that site champion monthly, separately, just one-on-one, me and that person, to talk about how's it going, are your needs being met, what challenges would you like to share? Can we adjust anything to meet your needs? So it was very collaborative. And this person also helped us collect data. We collected tons of data for this project, which we are still looking at and analyzing at the moment. None of it has been published yet, but we collected facility level data. So what patients or what number of patients are coming in, what services are they getting, what services are they providing to make sure that it's trickling down to patient care. We did interviews with the staff who participated at 3 different time points. So at the beginning, 6 months in, and then a year at graduation. And then we also did a facility baseline needs assessment in the very beginning to see where their services were at. And one thing that we were capturing both in facilitation sessions and interviews and in one-on-one sessions with champions are policy and practice changes. We wanted to know if yes, you're learning things and it's changing your mindset, but how are these trickling into policy and practice changes on the ground? We did try to collect patient data. It was very hard. And I can talk about that if people have questions, but we only ended up having 1 patient enroll. The jails were spread throughout the country, as you can see. The orange little star in California was a pilot site. We wanted to see if just having the mom care website without meeting with us regularly also influenced their policies and practices. So we didn't meet with them like we did the other ones. Like I said, 2 to 6 staff participated from jail. As you can see, it was a wide variety of roles and departments that participated, and many people were in leadership positions. Next slide. I'm not going to go through all of this, but these are some of the topics that we discussed in mom care. All of these align with topics that are on the website, but asynchronous activities we did some pre-recorded videos. Actually, Mishka was in one of them. The one that he participated in was about precipitated withdrawal for buprenorphine. I think jail staff are very afraid to have women experience precipitated withdrawal in order to start buprenorphine, and that came up very often. So we created a video for that. On the mom care homepage, there are 2 testimonial videos that we created with a jail that did not participate with us, and then some people with lived experience to help move culture change. We sent emails out. We try to do fun and innovative things. Next slide. I'm not going to go through all this either. There's a lot on here. But this is some of the things that jail staff did in that 1-year pilot period. So they shared mom care with their leadership. They put it in staff mailboxes. They put up flyers throughout the facility. Some jails put the mom care patient resources on resident tablets so they can look at it on their own. We met with one jail who was doing a request for a proposal. So like proposing their next healthcare for the following year. And so we embedded some mom care stuff into that. Some of the jails implemented training. We're working with the jail right now to implement ongoing training at their training academy. So there were many practice and policy changes. Here are some brief testimonials of people talking about the value of mom care, how they appreciated it, how it was a topic that they didn't realize needed so much attention and so much importance. One thing Carolyn and I did not mention, but I think it's worth mentioning, a lot of our policy and practice changes were around postpartum folks. No jail was screening for postpartum status. So with that 1-year question, have you given birth in the last year? Some jails weren't screening at all. Some were saying, are you breastfeeding? Others were, have you given birth in the last 3 months? And so we really communicate that the postpartum period is very vulnerable. And I think jails just didn't realize that, and they ate that information up, and many of them changed their screening questions. Next slide. Okay, last slide, pearls and takeaways. Pregnant and postpartum folks with OUD still experience withdrawal, trauma, stigma, and judgment. And this is even at jails that are doing MOUD. So still a long way to go. There are still lots of structural issues that disrupt and delay treatment. Services and support from people like you all are golden. Many jails partner with community providers and find it a lot easier for them to defer to the experts. But we would love to hear more ways that you all can support people in and out of jail. And of course, any questions you guys have. I know this was long, but thank you.
Thank you both so much. Gosh, your team has done so much, and this is really, really, really exciting. I love the story all the way from the first paper all the way till now. And I'm excited to share mom care with the jail that I work in. So I'll definitely be doing that. So I'm going to open it up to anyone who has any questions for Camille and Carolyn.
Thank you so much. This is an incredible amount of work, an incredible resource. I'm so glad that I know about this. I'm a family doctor and addiction doctor, but honestly, a lot of hospitals could be described in the same way that you describe these jails. Even in Seattle, there are hospitals where the internal medicine addiction folks will not touch the pregnant patients. It's a huge issue. I honestly think this website would be helpful for like a lot of addiction medicine doctors who don't know about pregnancy, which is like very sad but true. So I just wanted to say I think this is going to be helpful for a lot of people, even outside the jail setting. I think there's so much misinformation about pregnancy, and there's so much fear of treating pregnant patients. in outpatient and inpatient settings.
Wow, thank you for sharing that. I honestly had not thought about it as being useful for addiction, like non-perinatal addiction medicine providers. So
And
thank
like
you for that.
hospitalists, like general
Yeah,
medicine, a lot of hospitals don't even have an addiction medicine consult
right.
service. Yeah, so thank you so much. This is incredible.
Yeah, thank you. We've always we when we present mom care trainings and stuff, we always say we're not trying to turn anyone into an addiction medicine specialist or an obstetrician or midwife. Um, s- but I so to think about this being useful for people who already are is a little bit mind-blowing, and thank you for that perspective. I'm glad to hear that it might be helpful.
Katrina, you have a question?
I just saw Davida unmuted, so Davida can go first.
Oh, no, you got your hand up. You go.
Well, yeah, I also want to say thank you. This is amazing. I just sent the mom care link to the psychiatry and medicine corrections people at the big jail in Miami. And like today in our like case review meeting, we realized one of our homeless patients we've been trying to find on the street is arrested yesterday. And our rule in the jails in Miami is if you're on treatment from before, they'll continue it. But sometimes around pregnancy, we are able to get them to do more. Like I'm encouraging them to bring her to triage because she's 32 weeks with no ultrasound, no labs, no nothing. So we'll see what happens. But I think my question for you is actually about something else that you mentioned, which is just that we don't know that much about pregnancy outcomes for people who are incarcerated in general. And I'm just wondering, you know, yeah, I think that's very important. We see so many people that go in and out of jail, and we're really lucky. I'm at University of Miami, and we have a clinic, and our electronic medical record is kind of connected, so we can see when people are arrested. And we try. We're a substance use in pregnancy and a human trafficking pregnancy clinic, but we're like kind of. I'm interested in making us also like a peri-incarceration clinic. So I guess I'm just wondering about what resources or other directions.
Yeah, I'd love to talk to you in more detail about that than I can answer here. That um, there are certainly some models that are non-perinatal related with the Transitions Clinic network, but I think there's a lot of opportunity. So let's chat about that. And in terms of the lack of data, that's like the other parallel issue I've like dedicated my research to is documenting the number, how many give birth, how many. So yeah, we did a study with that, but are now doing a data linkage study with prison, but prison admission and release dates and birth certificates, fetal death certificates, and then like death certificates for infants and mothers to understand the link between incarceration during the perinatal period and maternal and infant death. But yeah, definitely happy to continue that. Hi, Davida.
Yeah.
Awesome. Carolyn and Camille, thank you guys so much. Your work is so fierce and also kind and compassionate in the way that you do it. It's really beautiful to see the arc of your work over these past few years. What comes next? I'm curious to know what you guys are thinking will come from the R34 work.
Thank
And
you. Yeah,
yeah,
thank you for your kind words and for asking that because I was going to see if there was time to get your input and also to thank you and your team for your research. We cite it all the time, especially that paper on postpartum. Well, you were an co-author on it. Anyway, so this grant, the Mom Care pilot, was an R34 grant from NIDA, and R34 are pilot grants, and it's supposed to lead into an RO what you're, well, not automatically funded, but you're supposed to then propose a larger trial. And so the plan was, maybe is, but to scale this up and deliver mom care with and without facilitation to a larger number of jails, like 50 jails. And we were just kind of, first of all, it was really harder than we thought to get our 5 pilot jails. And I am super well connected in the corrections world. I present at the National Sheriff's Association. I don't say that because I'm so great. I'm like, I have decided to go into the belly of the beast. And still, it was really hard. I'm very trusted and respected by corrections folks, and it was still hard to recruit just 5 jails. So I'm just like a little exhausted about thinking about, can I really recruit 50 jails? Also, I mean, we're now just we were like keeping the mom care URL a little close for a while, and now we're like, whatever, we got to share it widely. But also, there's a part of me that's like, can't we just share it? Like, do we need to study it? And sure, delivering, maybe it does help to have some of this technical assistance. I think it probably does, um, enough that it's worth a 4-year R01 clinical trial. I don't know. Maybe not. Also, they were interested in so many other aspects of perinatal care. Like maybe it needs to be broader than OUD. So I don't know. I know I've been, now it's 3 o'clock, but if you guys have thoughts, right now we've decided to focus on dissemination and not a clinical trial with mom care. So we're presenting, we submitted a grant from the Maryland Office of Opioid Response to disseminate to jails across the state. So anyway, would love okay, thank you, Zoe. Anyone else have thoughts?
I think, Carolyn, I run into this a lot myself. Like you get these grants in the research world and then you get to the next step, right? And I feel like in all the research that a lot of us do, we aren't doing anything that is quote just for science. We are doing things
Right.
because we are feel passionate about the science to advance the care for the people that we have the privilege of serving. So I'm just going to take this moment to
Okay, thank
validate
you.
your conundrum because I have been in the same space of,
Uh,
yeah, I'm supposed to be writing grants because that's my job, right? As a researcher, this and that. But also I want to like get this to the people that I know
yes.
would want it right now. And finding that, not I'm going to say balance, but just trying to figure out how you can quote do both is
Mhm.
challenging. And it sounds like to me that there might be a way for you to do both. I feel like
Mhm.
dissemination is 100% what you feel passionate about. Go for it. But I just would assume that your dissemination efforts are not going to get to everyone that
Yeah.
might be interested in using it. And so you might be
Mhm.
able to also use research dollars to really get into the quote, the belly,
Mm.
like you talked about.
Mhm.
So I would encourage you to maybe do both. I
Okay.
think data speaks a good story as I'm known biased as a scientist, like, and that's how we make change long term is with numbers and with data and feedback. But you can also help serve those that you want to serve at the same time. So I would encourage you to maybe search
Beautiful.
both and make sure that
Okay.
they can just work logistically.
It's beautiful advice. Thank you.
I just also, yeah, that was a great question, Davida. And I think the implementation science stuff is so important. We're trying to do like postpartum Nexplanons on labor and delivery and in our clinic, and there's nothing radical at all about it, but yet it is so hard. And it's, I don't even know how long Nexplanons have been available, like 20 plus years. And like we just started doing them in our hospital like last year. And so I think about next one on implementation science projects because that's how we're going to figure out the mechanisms of like actually getting the implementation done. So even though it's like horrible and I feel you, like it
Yeah.
I think it's like probably worth it, like
Hmm.
Camille and all of the like all of this work that you guys did. I have an R34 right now also, and I'm
Okay.
like, wow, hopefully I'm gonna get as much done as you guys got done. I don't know about that. But yeah, the next step, it is exhausting, but it's some of the stuff feels sort of basic and you may like think you
Mm.
already know it, but you kind of learn it through doing it. And then you can convince people like this is where you need to fund
Mm.
because the giving them the mom care link on its own didn't work as well as doing the technical assistance. So
Hmm.
more funding needs to be for technical assistance. I don't know. I know this is
Yeah.
being recorded, so but
Um,
seems
That's
worthwhile.
great. Thank you. And this also gave me an idea. I know we're at time if people need to go, but part of it is like scheduling and coordinate. We've been doing the technical assistance via Zoom, and that's like there's only so much that can do, right?
Yeah.
But we're only two people. Well, we have Mishka, we have a couple people, but maybe harnessing the expertise in WAG and having some sub awards and consultant
Mhm.
fees, although I know we all need salary support and that's what helps, like maybe that's part of it too, is that there are a lot of local disseminators.
Yeah.
because many of us, I say us, but I actually don't work in jails anymore. But many of you do work either in jails or directly with people who are currently incarcerated. So
Yeah. Yeah. Thank you, Carolyn. Thank you,
thank
Camille.
you
I'm
guys
going
so
to end us
much.
on that really positive, encouraging note. I think
Thank
that
you.
I'm going to encourage you guys to move forward on all the fronts because this is really good.
Okay, thanks. And Katrina, I'd be happy to talk about a perinatal clinic. All
Awesome.
right.
Thank you, everyone.
Okay, thanks. Bye-bye.
Bye.